remind everybody that the meeting is being recorded and being placed on the websites of Dundee City Council and the Health and Social Care Partnership for public viewing. And I'll do a roll call for the minute as well.
Thank you.
Beth Hamilton.
Present.
Councillor Lynn.
Present.
Councillor Toland.
Hi, I am here.
Councillor McHugh.
Present.
David Cheap.
Present.
Lynn Lloyd.
Present.
I've had apologies from Vicky Irons. Dave Berry.
Present, Arlene.
David Wilson.
Present, Arlene, thank you.
Susie Flower. Sanjay Pillai.
Present, sorry.
I've had apologies from Raymond Marshall. Jim McFarlane.
Present, Arlene.
I've had apologies from Christina Cooper. Liz Goss.
Present.
I've had apologies from Martin Sloan. Emma Fletcher.
Present, but with apologies, I'll need to leave at 11:30, sorry.
Okay, thanks. David Shaw.
Present.
Thank you. Christine Jones.
Present.
And that concludes the roll call.
Thank you, Arlene. Okay, that covers our apologies. Just to start, can I welcome David Cheap to his first official meeting? He's been an observer before, but I think, David, is this your first meeting as a participant? I think.
Yeah, thanks very much. I'm looking forward to actually getting more involved in this. That's me just been 2.5 months now on the board of NHS side, so been a bit of a baptism of fire, but yeah, this is the first one I can really hopefully contribute to on the IJB. Thank you.
Yeah, we're looking forward to working with you, David. Welcome.
Thank you.
Right, can we go on, Arlene, to take us through declaration of interest?
Yep, so item 2, declaration of interest. Are there any declarations? No, not seeing anything, so we'll move on to item 3A, minutes of previous meetings held on the 21st of February and the 27th of March, and they're submitted for approval.
Okay, thank you. You'll have had both of these sets of minutes, but we'll take them individually. So the meeting of the 21st of February, has anybody got any comments, any amendments they wish to make? No. Okay, could I have a proposer and a seconder, please?
I'll propose.
Thank you, Ken. Anybody second?
I'll second.
Thank you, Dorothy. So that's the meeting of the 21st of February agreed. We'll move on now to the meeting of the 27th of March, which were also attached with predominantly finance papers. Could I have any comments, questions? Nope. Okay, could we have a proposer and a seconder for those minutes then, please?
I'll propose again.
And I'll
Okay.
second again.
Thank you, Dorothy. What would we do without you two? Thank you, Dorothy. That's fine. That takes us on to, will I just go on to the action tracker, Arlene?
Yep, thank you.
The action tracker was there for everybody's information. I'm assuming that's just for information, Arlene. Are there any questions or points of clarity around those actions? Dorothy?
Yes, I think it says on the agenda for updating as well. I've got a couple of questions. Item 4, Mental Health and Learning Disability Improvement Plan. The update says this was to do with arranging specific development session for IJB members, and the update says to be coordinated as part of the programme of IJB development session on strategic planning. Is there any update on that?
Who wants to take that one? Who's Dave?
Yeah, thanks. Yeah, what we're still looking to try and do is get some dates in for development sessions. Given we've got some kind of changes in membership over the last couple of months, we're kind of looking to start those off probably kind of late May and into June, and that'll kind of give us back. So we'll have at that point our kind of new chair will have joined us as well, Dorothy. So we'll be getting those programmed into diaries shortly.
Okay, thank you. I've one further thing, Beth, if that's
Yeah.
all right. Item number 12, relating to the falls service. This was about including older people and carer representatives in the falls group discussions, and it says issue discussed at falls meeting on 9th of April. So that doesn't really tell us what the outcome was of those discussions. Is there any further information on that?
Catherine, are you going to come in on that one?
It's something that you want.
Yeah, thanks, Dorothy. We also picked this up in discussion with Liz and Martin earlier in the week, when we realised it wasn't really clear what the outcome was. So I've spoken to Matthew Kendall, who was leading on this. He's not here today, but he's confirmed that the group were very much in agreement that that would be a positive addition to the group and the work of the group. So they've agreed that, and they're now progressing identification of people from those groups who might want to join the group, and there's obviously various routes for us to do that as well. So Matthew's following that up as we speak.
Okay, thanks very much, Catherine. Thank you.
Liz, you were going to come in. Was that about the falls?
It absolutely was. That's good answers.
Okay.
Thank you.
Okay, that's fine. The one thing I was going to ask is, being relatively new, it talks about the date as the original time frame, but there's nothing to say when it's slipping. And I noticed everything's just gone on to June. We're going to have a very busy time in June. Are all these going to be discussed at the June meeting? Is that the plan, or are they, Dave?
So yeah, so some of them a combination of kind of substantive reports that will be kind of at the June meeting, but also this is those development sessions that we discussed in one of the last kind of questions. So yeah, there will be quite a few things at or due to kind of land at the June IJB meeting, and we'll can make sure that those that are meant to be there are there.
Okay, that's fine. Thanks for that. Okay, any other questions or points of clarity around the tracker? Nope. Okay. Item 4. Arlene, do you want to take us through that, or do you want?
Yeah, no, it's okay. I'll do it, Beth. Thanks. So it's Performance and Audit Committee, NHS membership appointments, and the IJB's instructions are requested.
Okay, so the Performance and Audit Committee, we're looking at membership, and reference is made to Article 3A of the minute of the meeting of the Integration Joint Board of 27th of March, wherein it was noted that NHS executive voting membership of the Integration Joint Board from the 1st of May would be Bob Benson, Beth Hamilton and David Cheap. It's reported that there are two NHS non-executive voting member vacancies on the Performance and Audit Committee, and the Integration Joint Board instructions are requested with regard to the appointment of Beth Hamilton and David Cheap to fill the vacancies from 1st of May 2024. Now that's because Bob is the 3rd member and he is going to return that week. He's returning in May. He's returning on the 7th of May, and he'll be taking over his role as chair from May. So David and I will be the representatives for the Performance and Audit. I hope that's not news to you, David, but you're very stoically taking it on board.
It was actually news to me when I read the papers. So yeah, just another committee to add. That's fine, no problem.
Thank you. Any points of clarity required around that? No. Okay, then that's great. We're doing very well. Oh, Dorothy.
Yeah, no, just to say, it says the Integration Joint Board instructions are requested. So do we need to approve this, or do we have to do something here?
I'm not sure. I'll go to the one with the knowledge, Arlene.
Yeah,
Is there any?
yeah, it just needs to be agreed, yeah, by the membership, yep.
My apologies, well done, Dorothy. Can we get approval from the membership for those two nominations? Thank you very much. Okay, we'll move on then to the Learning Autism and Neurodivergence Bill consultation. And I've got a note that it's Catherine that's taking this forward.
It is, Beth, thank you.
I'll hand over to you.
Thanks. So this is just a short agenda note to make sure that IJB members are aware of the ongoing consultation the Scottish Government are holding in relation to the proposed Learning Disabilities, Autism and Neurodivergence Bill. Hopefully the agenda note gives that reasonable summary of what is a quite long and complex consultation document for anybody who has looked at it in its entirety. It's quite a challenging read. But the main point is really just to inform the board that we are developing a response to that from a partnership and from an officer perspective. So we're obviously the consultation period ends just at the end of this week, so we do have now a draft response waiting for us to just finalise and submit later in the week. I think it may be helpful for the board to know that that response is broadly supportive of the principle of improving responses to people with learning disabilities or where there's neurodiversity, autism, etc. But we do have some concerns that the consultation suggests quite a diagnosis-led approach rather than something that's around a personalised approach to providing care, as well as some resource challenges associated with some of and particularly the proposal that there's mandatory training for the workforce in these areas and some of the resource challenges around delivering that. So it's not the principle of doing that, but how we would actually manage to do that in practice. I think overall we think we're quite well placed locally in terms of some of the developments that are being suggested, though, particularly around any potential for statutory plans in the future. And we have a long-standing and well-functioning learning disability and autism strategic planning group in Dundee as well, who've contributed to this consultation response alongside others as well. So as I say, we're now in a position of having a draft response that will be submitted at the end of the week from officers, but not as an IJB response. So this is really for your awareness. And we also know that there's a range of individual local organisations who intend to submit their own responses, including a couple of responses that are very much service user led, and one being from Wellgate Day Centre, but there are others that we know that are going in from a service user led perspective, which I think is really helpful. So I'll leave it at that, Beth, unless there's any questions.
Thank you. Any questions? Can I just ask a couple of quick questions? The first one, is it for children and adults, this bill? Because it doesn't actually say there. I know for the IJB, we don't have children, but obviously there's an impact in CAMS and transition. Is it just, is the bill for the totality?
Yeah, as Beth, so the consultation document is split into chunks around service areas, and we haven't responded to every area. There's a section around children and young people, there's a section around transition as well, so we've responded to the transition section but not others. I think not all sections are relevant for the partnership because it is a very wide-ranging and very lengthy consultation, but it does cover responses to children and young people too.
Okay, thank you. Dorothy, do you want to come in?
I don't have a question on this report, just to say thank you, Catherine, and whoever else has been involved in doing the officer's response. But there's background noise, Beth, that is quite distracting in the meeting this morning.
I think that's in Catherine's end, is it, Catherine?
Yeah, it's background noise in my office at home. Sorry.
Okay. That's fine, Dorothy, thank you. The only other thing I was going to ask Catherine, if it's okay, we've talked about the strategy we've got prepared and it's well advanced, etc. Will the addition of neurodivergence as a specific condition, or Is it a condition? I'm not sure what you'd call neurodivergence as a diagnosis, as an encompassing all. But will that make much difference? Because it does extend it again to, if you look at the spectrum of neurodivergence, and we could have that going on forever. Will that make many changes or add complications for the strategy as it is?
Yeah, because the strategy at the moment focuses particularly on autism in terms of the kind of neurodiversity aspect of it. So I think we would need to think about that, but it gives us a foundation to build on, I think, Beth, in relation to that. Part of the consultation is also about defining the scope of the bill, so it might also depend on any decision about what sits within the scope of the bill as well. But as I've said, I think our preference would always be to have a personalised approach rather than a diagnosis-led approach in terms of setting out some of the strategy and the response around about that as well. So there's a lot of those principles that would be the same across different groups and their different needs that we could build on round about that. But certainly I think we would need to do a bit of a stock take and consideration once we're clear about what the duties might be moving forward and the scope of those within the bill too.
That's great, thanks. Ken, do you want to come in?
Yeah, thanks, Beth. I note that the draft response is an officer response. Will we be deemed negligent in any way by not submitting a response from the partnership itself, the IJB?
No, it's been an approach, Ken, that we've used for a number of responses, and there's never been any concern raised. That's common practice across boards as well. There are some, I think the National Care Service one, for example, where the board has seen the response and things, but that is quite common practice for us to respond at the officer level for this type of consultation with this scope as well. But more than happy if there's any members who have a particular interest and want to have a chat, an opportunity to make any comment, to do that over the next couple of days and to reflect that in the draft as it is at the moment as well. Can do that off table with people, no problem at all.
Thank you.
Okay, thank you very much. So if there's no further questions, the IJB is asked to note the consultation and intended approach to developing a response. Are we all happy to do that? Okay, thank you. Arlene, can you take us on to the next one, please?
Yep, that takes us on to item 6, which is the Tayside Primary Care Strategy update, and you're asked to agree the recommendations.
Okay, I'm assured that that's Shona. Shona, welcome. Could you take us through this one, please?
David was actually going to speak to it as a signatory.
Right.
Jill Galloway and David sort of co-authored the paper, but Jill sent her apologies. She had a conflict today. I'm happy to add, but David will kick off.
Sure.
Apologies, David.
Thanks very much, Beth. So in October last year, we came to the IJB with our plan on the page, which is sort of first marker for our primary care strategy. And we said we would come back in February with a further iteration. Subsequent to that, as you can see in the paper, there's been work done on a Tayside strategy, which largely encompasses what we were wanting to do with the primary care strategy. So it's been agreed to fold the primary care strategy into that Tayside strategy, which means that there isn't a requirement for us to come through as we said we would. And I guess if we say that we're going to do something and we do something different, then we should probably tell you about it. So you can be assured that there is ongoing work in terms of supporting those aspects of primary care where there is necessary improvement and necessary additional work to take place, but there won't be that primary care strategy coming back to the IJB as indicated. I'll pause there and see if there are any questions. I think you're asked to note that this has occurred.
Okay.
Thank
Dorothy?
you. Yes, I wasn't really sure what this meant. You know, there's now going to be an NHS Tayside strategy. Is that the same? You know, will we still have a Tayside primary care strategy? It's going to be embedded in a much larger and wider document, is it?
Yes.
I'm not sure if is that a good thing?
I guess the there is a significant amount of work in producing any strategy. You want any strategy to be useful. We are doing extremely useful work with regard to several areas that within the strategy just now that this allows us to concentrate on to a greater degree. So we've embarked on work in premises. Some of that's coming to the committee in our following item. The significant work that we're doing with regard to GP sustainability, and there'll be a set of sustainability reports that will be coming to the IJB with regard to this. So I don't think we're losing anything. I think the important thing is that we continue to do necessary work. So I can understand why there's been a decision made to fold the primary care strategy into a wider strategy. I think that the big concern that would be understandable to have is, do we lose any momentum as a result of that? And I think we're very conscious that we want to make sure that the problems afflicting dentistry, general practice particularly, are captured and progressed. And absolutely, where that touches on the partnership, then the partnership will be kept well abreast of that. So I think papers such as the one that we're moving on to next, but themed, will still be coming here.
Thanks, David. That it was my concern that something might be lost, and you know, and I still have a wee concern about how the Teesside primary care strategy can itself, which is part of a much wider document, can be properly monitored and scrutinised. You know, it might get lost. I still have a concern about that, but I'll take your reassurance, David. There'll still be updates coming back to the IJB specifically on primary care within Teesside.
Yeah, I think that's what Shona's going to come in about. Is it, Shona? Sorry, David, if you'd like me to take Shona in first.
Yeah, I guess there is a risk, as Dorothy's highlighting, in terms of losing some of that locality and the detail around that. But certainly for the general practice primary care component, not so much around the other contractors. We have got our GP strategy that came to the IJB at the end of last year that's Dundee specific in terms of our local delivery. So we're not removing that. We will continue to work on that and we'll continue to report on those local things. So I think, Dorothy, your point is around some of the wider contractors and wider sort of generic issues across Teesside and how we pull that across to ensure we're reporting that at a local level for the IJB. And we need to work out how to do that. So I think it's an important point, and we can work as a team across Teesside to do that. But certainly the GP strategy and the other strategies that we've brought to the IJB already will continue to develop and refine with the Dundee specific elements in it.
Okay, thank you. Dave, are you coming in on that same question?
Yes, thanks, Beth, if you don't mind. I think as well it's important to note that the sustainability of primary care is one of our key strategic risks as well, Dorothy. So it's on the risk register too. So the IJB will continue to be kind of cited on anything around the risk associated with primary care through the Performance Audit Committee on a regular basis, but kind of any issues are escalated back to the IJB. So just to give you that further assurance that it won't be lost to us in that respect.
Okay. Is that okay? Is that are you happy with that, Dorothy?
Yes, thank you.
Thank you. David, thank you for your patience. Would you like to come in now?
Yeah, no, thanks. Mine is actually a very simple question, and it's more for the avoidance of doubt. Just in para 4.3.1 under communication and engagement, it refers to a subcommittee meeting held on 15th of January 2023. Is that right, 2023, or was it actually 24? Just out of interest.
That'll be 24. Sorry, that's an error.
Okay, so it was just purely for a matter of correction. Okay, that's all it was.
Well spotted.
I thought it
Yeah,
was. Thank
well,
you.
well done, David, for your first meeting. You've spotted
Should have
something.
read the papers.
It does. It does. Well done.
Thank you.
Okay. Any other thoughts or comments? Okay. Well, we've been asked. The recommendations are that one, that we note the work undertaken to revise the Tayside. Oops, my computer's just jumped. Note the work undertaken to revise the Tayside Primary Care Strategy Plan on a page. Oh, we never touched the plan on the page. It was there as an appendix. Very busy plan on a page, but a plan on a page would be. Are we all happy to accept the work undertaken to revise the page on a plan on a page? Excuse me. Are we all happy with that, David?
Sorry, that's a legacy hand. Sorry about that. I'll get that down.
That's okay. Dorothy?
Yes, the plan on the page. Thank you for reminding me about that. I did have a wee question written here. What is the point of a plan on the page? Who uses this? Who is it designed for? You know, I find it really busy and the font size is so small because everything is squeezed in to get on a page. I mean, what is the use? Is this a useful document and who is it useful for? Because I couldn't actually read it.
Sure. So plan on the page was originally developed as part of expressing the primary care strategy in a way that could present an awful lot of information in a relatively constricted space. And apologies, that has meant that because we try to cram in that much stuff, the font size makes it challenging. I guess the purpose is to make sure that patients, those who work within general practice, clinicians, those who work with primary care in all of the contractor streams, but maybe not embedded in primary care, are aware of where our various different priorities are. It's internal messaging for those various different contractor streams, and it's also for bodies such as this, so they can get a snapshot of the ethos, the direction, that sort of thing. So there's a variety of different functions. Absolutely. I do have to take my glasses off in order to see that. So I take that on board.
Jonah, do you want to come in on the back of that?
Yeah, I was just going to say I can maybe link with my colleagues that developed it to see if they could produce another version that maybe has less information on a page, but so that it's just chunked up slightly differently, because obviously it probably wouldn't meet accessibility criteria in terms of reading and things, depending on how your computer works to be able to enhance that. So I'll go back to the Angus team that led this and ask if we can have a slightly simplified version.
Okay, thank you, Shona. Ken, do you want to come in?
Hi, yeah, I agree with some of Dorothy's comments there actually about the page is quite crowded, it is quite hard to read, but I appreciate what David said. We're reminded on the plan on the page that dentistry is a part of primary care. I think that's often forgotten, and I've mentioned this previously, that I don't ever recall us having a discussion on dentistry, and we're talking about primary care today, but only in the context of GP practices and associated services as primary care. We've never had a report on dentistry. Can I ask that a report be brought to this committee in the near future, certainly this year, hopefully in the summer, to appraises of the situation with regard to dentistry, because I think it's as much of a concern for people as general practices. Hear about the difficulty that some people have in getting appointments. They don't like having to have to phone the surgery and stuff, but we never hear anything about dentistry, and so many people have problems with dentistry. So that's an ask, really, if we could have a report on the Dundee-wide situation as regards dentistry, particularly NHS services. Thanks.
Okay, Shona and then Emma.
David might want to add to this, because with his Tayside primary care hat on, obviously he's got a remit in this, but Ken, I am aware you've raised this before, and I've spoken to Debbie McGill, who's my counterpart in Primary Care Services Department, to say that there had been a request for a report. So it's just been a capacity issue that we haven't been able to do that, but we have started to have some discussion about the requirement for the IJB to be a bit more cited on this, so we'll take that forward. I'll link with Catherine and others just around the best timescale for that, because if there's a June meeting that's busy, it might be after summer, I would suspect, before that would be able to be fitted onto an agenda. But it is an important area for people. Dental health has a big impact for all sorts of reasons.
Okay. Emma, do you want to come in?
Yeah, I might be able to help connect the dots on this. As you flagged, Ken, it is a significant concern, and it's a significant public dental health concern. We have a consultant in the department who's been working closely with colleagues, the Director of Dentistry and Angus colleagues, and has done a comprehensive health needs assessment with regard to dental provision and the health needs of people who need to access dentistry services. That is in the final stages of completion and is being progressed through Angus Angus executive team in the first instance, and then there will be advice as to how that gets disseminated across Tayside and shared more widely. The provision of dental services is complex, and David and Shona will be able to advise further on this. The bulk of the primary care service delivery is hosted in Angus IJB. The inpatient responsibility is with NHS Tayside, and the public dental services is hosted and responsible by the Perth and Kinross IJB. So we're in the process of advancing work in this area for all the reasons that you've outlined, Ken, and hopefully we will be able to disseminate that much more widely once it's gone through the initial Angus structures, because they were the commissioning body, but it is a Tayside-wide picture and perspective given absolutely everything that you've highlighted. Hope that's of help, and hope that's of help to you, Shona, also.
Okay, thank you, Emma. David, do you want to come back in?
Yeah, just on the subject of dentistry, absolutely. There's limited access to NHS dentistry for both adults and worryingly children. We have invested significantly in our public dental service, which helps to mitigate that in part. Dentistry is complex, given that an element of it is delivered privately and an element is delivered publicly. And that is one of the main differentiating factors between the dental situation and the general practice situation. There isn't really a big market for private general practice services. It does mean that the specifics with regard to the dental contract can push dentists one way or another into either NHS or private provision. And that comes with significant impacts on patients, given the costs associated with dentistry. So certainly we can come back with an update of where we are in Dundee. I would say that deprivation and dentition are very closely linked. There is a need to have to be on the front foot, therefore, particularly in communities such as Dundee, and particularly from a young age. There's been significant investment, I think, in the Child Smile programme to try and make sure that we embed good dental hygiene and good dental care at an early age so that people can retain their teeth. And absolutely huge health consequences if you aren't able to manage that. So it is a very important area.
Okay, thank you for that. Well, we kind of got diverted a wee bit there on the dental, which is a very valuable discussion, and thank you for bringing that up, Ken. But could we just go back and note the work undertaken to revise the Tayside Primary Care Strategy Plan on a page, which Shona's going to take back and look at, and also to agree that further work required to produce a Tayside Primary Care Strategy is adopted into the system-wide approach to develop an NHS Tayside strategy in total. So are we happy to note that? Okay, Thank you for that. That was a good discussion. Can we move on again in the GP land now? Specifically, can we look at the general practice premises strategy update? Shona, you've got that one again.
Yeah, I'm good at delegating today because Julia's going to start off. She pulled most of the paper together and she did the original work on the paper that came previously. So she'll start off.
Thank you and welcome, Julia. I will hand over to you then.
Thank you, Beth. Good morning, everyone. So this morning I'm updating on the general practice premises strategy along with David and Shona. So I want to give you the progress that we've made to date, and then we'll give you annual updates going forward. So the work that we'll go through has been funded through a combination of different mechanisms and funding sources. And we all know there's limitations to the funding, and we don't know what's available in the foreseeable future. So that will affect some of the plans that we have. And also the loans to support sustainability of practices is also unclear. So a bit of a moving picture for us. But the general practice premises strategy that came before you in October 2022 included recommendations and actions over about 20 years. We tried to look quite far forward with it. And it set out 4 broad criteria that we would try for a community-focused model to deliver our health and social care, that we would have premises that were of good quality, that practices would be sustainable, and as you heard earlier from David, you're going to get a set of reports coming to you, but there is a significant piece of work being done by another programme manager for primary care services to look at sustainability, which includes a framework risk matrix that surveys the practices and is collating data. So you'll hear about that in due course. We also wanted to ensure that the practices we have provide appropriate geographical coverage and equitable provision. So in terms of the actions that have happened, the things that we've achieved. So the first action that we had was that we wanted to improve premises and set out a programme of works, and at point 431 the list of the works that are underway or have been completed. So I won't run through those, but I'll leave you to have a weekly look at those. Action 2 was to take a strategic view on the longer term viability of individual premises. So for example, where a premise has a lease that's due for renewal, we need to assess whether we still need that premise. Is it in the right place? Does it fit with our strategy going forward? So to be able to assess that, we've done work in a number of ways, which is including setting out steps for lease assignations and the development of a database that draws together a significant amount of information about each practice. This information has been done at NHS Tayside level and will help us and inform decisions about the need for premises in particular areas of the city, the state of the fabric of the building, the utilisation of the space within that practice as well. Action 3 was around an equality impact assessment. That's been completed, and we'll update that on an ongoing basis. And there was as well the extensive public consultation around the premises, and we continue as a team to actively engage with citizens. So one example of that is that the installation of TVs into the GP waiting rooms, and this is part of helping with access to the services that are available within those practices. So we're looking now at a 21st century solution because it's a TV, but it's also coming with an online media player. And we have something similar in Ninewells. So we'll be creating information that will inform patients, and we will obviously work with patients closely to ensure that what we're creating makes sense for them, so that they understand these services and how to access them. Action 4 was around the green agenda and achieving net zero, and we have a couple of examples of that with the installation of grounder air source pumps and the Reforest initiative with the Family Medical Group at Douglas. Around Action 5, there was an ambition for new builds and trying to explore different ways of working. That's not been feasible in this current climate, so that action hasn't progressed. And the final action, just to update you on, was that we were looking to appoint a project manager to help drive forward some of the GP premises strategy. we got agreement, but it hasn't been implemented. But what we have got is some resources coming across to help us in other ways. Some of that is around the space utilisation in the practices. In terms of the risks, there's 4 there, but I think the main one to note is the one around the investment and the funding for doing that work. And that's it, and I'll hand back to you, Beth. Thank you.
Thank you very much. Julia, Shona or Dave, do you want to add anything before I open it for questions? Nope. Okay, can I open up for questions? Can I ask, first of all, Julie, you talked about the approval for the funding for the post for the project manager, and you're saying, have you any intention of using the funding to employ the project manager, or are we permanently going to be using it in other areas?
Can I give that one to you, Dave? Very.
Yeah, I can come in on that
sorry.
one. So yeah, Beth, it's kind of the kind of establishment of that post was kind of sitting with myself to try and get that one embedded. It has been quite difficult to kind of agree a sort of level of that kind of post, and also the kind of the job description and the grading process, which takes some time to do, particularly in an integrated world where it's you have to do a council one and an NHS one, etc. So we've kind of had a kind of rethink around how we might wish to do that. Currently engaging with the Director of Estates at NHS Tayside around approaching about provision of almost like a commission service from them directly, and utilising their existing resources and dedicated time for Dundee to develop the kind of work that's required on a local basis on that. So that discussion's kind of ongoing just now. I'm pretty confident we can get a solution there which will give us access to the kind of professional services that we need, and enable us to kind of take forward this piece of work.
Okay, that's good. Thanks for that. Okay, we'll move on. David, do you want to come in?
Yeah, thanks, Beth. Let me just get my papers up again. I had an interest in action 2 and action 3 here. If I could maybe ask the question on action 2 first, if that's okay, and then if you don't mind me coming back to look at action 3. I was just interested in the wording saying that some leases are drawing to a close and a number of leases are due to expire, and some practices are looking at lease assignation. If it's they're looking at lease assignation, is that to other people taking on the practice, or is that getting out of the practice altogether and assigning a lease to another sector? What altogether? I'm not sure. I know I'm quite new to this. I'm not quite sure what all that. I'm quite a lot of background in property and lease management, and but I just wasn't sure here whether on the assignation does that mean to other practices, or is that out of that NHS altogether? We could have that one looked at first.
David, have you put your hand up to kindly answer that one? Thank you.
Absolutely. So lease assignation in this is NHS Tayside taking on the lease with a license to occupy for the practice. So there were a set of policy choices made in 2018 by Scottish Government to try and reduce the impact of holding property on general practice sustainability. Conventionally, most leases for general practice properties are over periods of maybe 20, 25 years, and they commit the practice to continue to pay rent for that period of time, regardless of whether the practice is a going concern. If you've got practices that are at risk of falling over, then it would tie in the partners to potentially paying several millions of pounds that they maybe don't earn. GPs aren't quite that well off, unfortunately. Speaking as a GP, I wish I was. Therefore, they struggle to recruit if they hold premises in this way. So if you exist in a health centre building, then there is no such tie-in. It is easier to attract people Maybe part of the reason why, one of the many reasons why Westgate is such an attractive place to go to. It's a health centre. There is no property risk associated with it. There is a property risk if you sign up to a 25-year lease. Similarly, if you own your building, then you conventionally sell a share of it when you retire to someone who wants to come in. And again, that may be several hundred thousands of pounds of a mortgage. Now, there are means of reimbursing GPs for their property costs, but there's still real financial risks associated with this. The sustainability loans that Scottish Government introduced deal with premises that are owned by practices, and they there is a programme where over 25 years these can transition into NHS ownership through sequential loans on a 5-yearly cycle. The only circumstance in which another sector would come in would be if a practice closes. So we've had a number of practice closures in Dundee. I think the most recent one was at the end of last month when Park Avenue closed. That was owned by the partners and the former partners, and they continue to own it. So the short answer to your question is no one else will be wanting to adopt these leases. It would be for the NHS to adopt a lease with the assumption that a general practice will continue to operate within it under a license to occupy arrangement.
Okay, all right, I get that part. That's the last bit. I understand it now. Okay, that's fine.
David, did you notice in the chat that Shona's put up in chat that she'd be happy to have a chat with you out with the meeting to go through it in a bit more detail?
As well, yeah, that's fine. Can I just address 4.3.3 as well, please?
Of course.
Just because that one, I'm really interested in this because clearly that's service levels are being looked at here, and when we're talking about EIAs on digital phone appointments, would that also include the use of the strategy of near me? Because having talked to people in IT, I think there's only one practice that's actually utilising that, and I see that, from my limited understanding, as being a huge step forward to getting waiting levels and everything down and avoiding the travel, etc., because near me obviously allows you to actually see the patient's records and also visually see the patient as well, because so much of that's so important to see the patient's face. So I'm just wondering if that action point will include that as well, because it seems like a bit of a missed opportunity if it's not.
Okay, I'll hand that Shona. I'm assuming you're coming in on that one. Thanks.
Yeah, we've looked quite a lot at the use of near me within general practice. It was used fairly significantly by some practices at the beginning of COVID. That was kind of when it was rolled out, but the experience for everybody has not necessarily been positive within general practice, and certainly as part of the consultation work that Julie undertook when we were doing the strategy, most of the public did not want video consultations. They're happy with either phone or face-to-face, and face-to-face is by far preferred. Now, I know for a lot of people sitting around this table, they'll say, well, that's absolutely not the case for me. It's much easier for me to have a video consultation, but the practices do offer elements of choice. So things like First Contact Physio and PAMS as well look at using near me, and even when they offer choice, there's very, very few people who take it up. So we've got a real mismatch in terms of how the technology could help us, but we are trying more time consuming for the practice. So it's a really difficult debate to have with practices at the moment, because it actually takes time.
Okay. Okay, thank you. Dorothy, would you want to come in?
Yes, so I was so interested in listening to that debate, I almost forgot what my question was, but luckily I'd written a note. 4.3.1 talks about the premises improvements, and I'm just wondering, clearly these will be affected by the funding constraints set out in 3.3, and the risk that on the risk register now, risk 4, Is that a huge concern?
It's a significant concern. I think the funds that I think I mentioned in part in 3.3 relate to sustainability loans, and these have been paused. We may hear a little bit further towards the end of the year as to whether or not SG have managed to identify to capital. I think there's been some accountancy restrictions that meant that they couldn't tap into a source of funds that previously could be tapped into. So I think this is an area that's under review. There are obviously capital concerns elsewhere within both Scottish Government and NHS Tayside. There's a limited pot of money for any change. So I think that there are going to be risks beyond the sustainability loans as well.
Okay, Shona, do you want to come in on that as well?
Yeah, I think we do have concerns, as you would imagine, around capital. I mean, it's been well covered in the media around capital changes at Scottish Government. So there's kind of two different capital pots that we've had. NHS Tayside have capital, and there's a small amount of that allocated across Tayside for primary care, but it's quite restricted in terms of which buildings it could be used for. So if you have a lease, then you can't access that funding. And we've also had a small amount of money came to us directly at the Health and Social Care Partnership a few years ago for capital funding for improvements linked to primary care improvement, and we've managed to do some of the work with that, but neither of those are certain going forward. You've then got the bigger capital projects that we would have been looking to bid for, and obviously Pat, as the chair previously, was really keen on sort of significant development in the multi-centre and multi-agency type buildings, because she had a lot of experience of that. So I think there's a low probability of that type of work progressing as things stand at the moment.
Then Liz is next, but is your question a part of this discussion, this topic, or is it something different?
My question.
No, I was saying I was going to bring Ken if it was joining this conversation, but if it was a different question, I was going to go to you, Liz. You've been waiting patiently. Ken, is your point part of that discussion?
I'm happy for Liz to go
Right,
first.
okay, thank you. Liz, you've been waiting patiently. Would you like to come in?
Okay, just a couple of things to say. One was it was really promising to see how involved the community have been in this discussion and about what the future model of care will be. So I think that's to be commended. And my question was around about, and maybe it's for the councillors, I'm aware there's lots of new buildings that go up, and the developers sometimes provide funding for schools, roads, and in some cases general practice. And I'm just wondering, is there any possibility of that funding being encouraged more than it currently is to go towards general practice? I'm really not terribly sure about the planning process and how that works, but I'm aware there's sometimes quite significant funding that goes towards schools, for example, or roads. And I'm just wondering what the potential is, or if there is any potential there.
Shona, are you coming in on that?
Yeah, so helpfully Liz had highlighted to Catherine this question, and it's something we've been speaking about for quite a period of time in terms of how we get a unified approach across Tayside. And I know Dave had a meeting a couple of years ago. One of the challenges we've got in Dundee is certainly in terms of general practice demand. A lot of the housing that's being built at the moment is on the periphery of Dundee. It's outside the council boundary, but people come into general practice for their services. So how does that sort of cross-boundary working help in the sort of trying to avoid competition in the different areas? I spoke to one of my colleagues in property. So there's no formal agreements in place in Tayside at the moment, but the issue is that it's across the whole of health. So how do you, so because of the very geographical nature of schools and able to sort of population plan, it's relatively easy to say what you need. Any developer contributions have to be towards a specific building. It's time limited. If it's not used for that build, then it has to be kind of almost handed back. How do you work out what you need in general practice or an impact on a hospital setting or some of the other services that we have that work out of other types of buildings is is really quite complex. I think one of our challenges is trying to work out a mechanism to support this happening. So there's kind of a principle thing, which I think is what you were highlighting in relation to councillors' views on and whether this should be supported at a local level. And then there's the actual mechanics of being able to find a mechanism to say this is what we need to support delivery of care going forward in these different settings and how we would actually do that.
Thank you.
Okay. Liz, does that answer help?
Yes, I'm sure it is quite complex. It just, when things are so tight, I suppose I'm just thinking, is there any other source of funding that could help you? That's great though, thanks Shona. Okay, thanks Liz. Ken, do you want to come in now?
Yeah, a couple of things. Just a brief observation on what Shona was saying about near me. I would have thought it would be a no-brainer that if I was offered a telephone appointment or near me, when I can see the GP and the GP can see me, would be the preferred option. So I'm wondering, is this this unwillingness to use that medium, is it due to a lack of the technology that's required, or even if the technology is there in the patient's home, are they unfamiliar with how to use it? I'm attending, I think it's next week, what is it? Not a seminar, it's an open day, I think, for increasing the use of digital technology for older people. Which, you know, that's the older you get, the more you need to use a GP. So it'd be really good to see digital education being rolled out even more than it is, to enable people to use what I think, as I said, it's a no-brainer that it's better that the GP can see you, that you can see the GP. So I think there's a digital skills gap there, a big digital skills gap, which we not just we in the Health and Social Care Partnership should be looking to bridge, but I think everyone, every public body should be looking to try and bridge that skills gap. And the other brief question I wanted to ask was about the action point. On action point 1, yeah, can just confirm that the works which are underway won't be affected by the financial implications, which are very concerning, listed at point 3 in the agenda. So works underway will be completed. There's no issue there, or?
Yeah, I think Ken, you win the prize for generating the most questions. We've gone up to 7 questions now here. So I'll go to Shona first, and then David, and I'm sure they want to comment on your first point, and I think just confirm the second. Shona.
I'll take the second point first. So yes, Ken, the things that are listed in 4.3.1 are all underway, and we've got secured funding, so they're not dependent on this year's funding. So that is okay and reassuring to an extent. I think we would all agree with you about the digital literacy within the population. I think there's quite a lot of data out there that suggests that people do have access to equipment for the majority of people, but not necessarily everybody. And our colleagues in DVVA do some work around this. And there's been some project work in local communities trying to support access through community centres and things. Sometimes we're just a little bit challenged in terms of trying to marry that up. On the professional side, the practices have equipment, so it's not at the professionals end that they don't have access to equipment. So I think your point's important. We did go to the Digi event that was held just a few weeks ago down at the Steeple. One of the team was there, and there's again not huge interest. I think it'd be interesting to get David's view, and that might be why he put his hand up. So phone is still very commonly used, but often the professionals find phone and photos actually gives a better if you're needing visually to see things. So things like rashes and things come out much better on photos than they do on the video cameras and things. So sometimes there's a quality issue, but David would be best placed from a clinical point of view to answer.
Okay, David, over to you.
Thank you. So I guess there's patient factors and there's clinician factors with regard to why we have obstacles with near me. So I'll put my first sort of conflict of interest up. I do use near me both in hours and out of hours, and it's particularly useful in certain circumstances. So if you're needing to see something, for example, the way that the child is breathing, to determine whether or not the parental concern is something that's an emergency that needs to be dealt with, for example, through an ambulance call out, or whether it's something that's less urgent, then being able to see absolutely gives you a benefit. When it's a talking discussion like this, absolutely you do get more information from seeing the other person's body language. You feel more engaged with the call. But on the other hand, from a patient perspective, often these phone calls are at times where a patient may not necessarily be best placed to actually have a video call. It's a lot easier to call when you're out walking the dog than other places. If you're phoning from your work, for example, then video call might be a difficult thing to take. I think the way in which near me consultation takes place, I've had near me consultations with my my child as the patient up at the hospital. It's a question of, ordinarily you get sent a text message. You open up the text message on your computer or other electronic device, such as a phone or a tablet. There can be specific technical issues in doing that, so it's not seamless. If you haven't done it before, you need to be able to troubleshoot camera and microphone issues. So there are some specific issues that have meant both clinicians and patients have had bad experiences of it. And we still have a degree of conservatism with regard to certain aspects of technology. That means that there are a group of people who just do not want to do this thing. For things that you want to look at, if you want to send off an image of a funny looking mole, then what you'll get from a photo as opposed to a near me is a documentation that will be stored in your record, and which can be sent on to a third party, such as a dermatology outpatient appointment. So there are specific issues as to why you might want to choose a photograph rather than anything else. But absolutely do find that seeing people adds an additional layer to what you're doing. It also takes time to set that up, and I think that's the other clinician factor. It's a lot easier to set up a phone call for both the patient and the doctor than it is. So I think that's part of it. I think finally, there are relatively few people who are medical who want to use near me because they haven't used it on a regular basis. So personally, I think that all of our GP trainees should be exposed to it, because you should be able to be competent in all means of communication, including video calling. So when I do my out-of-hour sessions, I try and make sure that all the trainees who are on with me have the experience of being able to use it, so they can see the benefits behind it. I think it's been oversold in some places, so it's very easy to be enthusiastic about it. I'm a bit enthusiastic about it, but I recognise that it has got limitations. So I'm sorry if I went on a bit about that.
Oh, sorry, I'm waiting. Liz coming. I've asked Liz. Liz, sorry, would you like to come in with your question? I had my mic on there.
Sorry, I don't have a question. I wonder if there's a...
Oh,
there. Sorry.
okay, that's fine. Siobhan.
Thank you. Just going back to the housing development question, and the obligation sometimes for developers to build certain buildings, and that kind of question over whether GP practices or other medical practices could be done. I mean, I'm kind of deputy convener of kind of framework and economic development, and it is it's one of the discussions that we've been having as part of the city centre development plan, because one of the plans is to kind of actually have more general housing within the city centre, is that kind of 10-year projection, and how we fit GP practices and medical services within that city centre structure. So there's been kind of tentative discussions about how we manage the increase of medical facilities, especially in a kind of city centre basis. It might be worthwhile.
Siobhan, you've gone on to mute. I don't know why you're muted
myself. Where was it at? I was just about to say that,
you just missed the end there. So you
brilliant. I was it might be worthwhile. I could raise it with Robin and Gregor from planning, just to see if there's any discussion that might be worthwhile being had between planning, economic development, and the IJB as well.
Okay, thank you for that, Siobhan. Okay, David Cheap, do you want to come in?
Yeah, thanks. Just I'm just interested in listening again to the conversation of people with Ken and David on the near me thing. I think I don't want to labour the point, because I'm kind of a bit staggered that there's the response on it in some respect, because what I hear, as a user as well of all this, is that people are saying, okay, I can't get an appointment at my GP. And what people want primarily, as we know, is to attend a GP practice and be seen face to face. We know that's the standard that everybody is looking for. But when they hear that all we can get is a telephone consultation, I get a lot of complaint about that. And I think an awful lot of people aren't aware of the possibility of a consultation like we're having today, where you're seen, and I've been told the benefits of being able to see someone's face, because they might tell you nothing's wrong, but a GP can see from looking at them or whatever that something is wrong. But I think a lot of people out there don't know that's available or would be available, and I think as users they would absolutely embrace this, because the fact it's a midway step between seeing a GP face to face in the health centre, as opposed to a telephone consultation, which they don't really like. And I think, to be fair, I know there are people who will not embrace IT. I get that completely. I have an 85-year-old mother-in-law who uses her iPad to do her banking and doing everything, and would love to have a GP consultation face-to-face on an iPad. So I know there's levels of people, but I just don't think we're embracing it enough personally, and I don't think the public know that it's available, and I think they would embrace it an awful lot more.
Okay, this is interesting. We've got 3 Davids looking at this on my screen to come in. So we'll take David Shaw, then David Wilson, please. David Shaw.
Okay, I guess a point for David and one for Siobhan. So in terms of near me, absolutely, I think there's a place for it. I think in terms of being midway, it's not. If you've got a phone appointment and your choice is a face-to-face, from a clinician perspective, it will take less time just to book a person in for a face-to-face appointment. The only thing that a near me will do is mean that somebody isn't sitting in your waiting room or isn't taking up a car parking spot. It will take probably more time than doing a face-to-face, and you've got the risk that you'll have to then bring them in for an examination as well. So I think that's the reason why a lot of practices go telephone or face-to-face, and more practices I think are going face-to-face. There are specific groups for whom face-to-face is especially difficult. So if you're struggling with transport because of physical infirmity, I think there's a real place for near me in that sort of situation. If you're providing remote support to somebody, then again, it can be useful. And absolutely do think that there is something to investing to a greater degree. As I said, it may not come across it, but I am relatively enthusiastic about near me compared with my peers. I see that there is a place for it, but if you notice, I'm not exactly mega enthusiastic about it. And that is simply because it does take a lot of time. There is the question as to why would you do this thing if you could get more just by seeing people in the surgery? I think part of the issue is that the real problem we've got in general practice is there are not enough clinicians to see all of the people who need to be seen. And that is part of the reason why we have a telephone first in many places, because they're trying to separate out those patients who can be perhaps directed to other clinicians who need a face-to-face, who can have their problem resolved over the phone. And that is profoundly different and also often quite unsatisfying to experience. So it is a big tension. Near me is a little bit in there, but as I said, it is a little bit of a much bigger problem. As far as the bit with Siobhan goes, there are lots of practices situated round about the city centre, and currently their premises aren't brilliant. So if you have a look at specific practices, I think certainly reprovisioning in specific locations would certainly be something which I'm very sure that some practices would be very keen to explore. So it's not necessarily the number, but the premises themselves. I think there's constrained parking. There's room layouts that are more suitable to the 1950s than the 2020s. So I think there's a bit of work that we'd be very interested to do there.
Okay, thank you, David, too. And David Wilson, welcome. Would you like to come in with your point?
Thanks, Beth. Yeah, I guess just mostly in support of what David Shaw was saying there, I think the perception that near me is going to improve GP capacity is probably not necessarily a realistic one. It's certainly exceptionally time consuming in my experience. It is something that practices can offer and have access to be able to offer. But I think the perception that it's going to suddenly be able to soak up any of that excess capacity is maybe not a realistic thing. I guess it has its roles within out of hour service and potentially in secondary care, where it's a more Tayside wide practice population and people are having to travel quite far. In Dundee, more and more the practices are moving their boundaries so that it's their local population and access physically isn't as much of a problem. And I think the other thing I would say about it is it's maybe good for the more planned care where you know you have a telephone appointment in a week's time on Tuesday at X o'clock, but more and more because of the capacity issues around practices and the accessibility to appointments, people are feeling that their problems need dealt with that day, that morning, because they can't wait that time or there's not the scope to offer that time. And therefore, from a clinician's perspective, I can't have pre-booked near me calls as well as deal with the on the phone demand, which may well require a face-to-face assessment. And so my priority has to be dealing with the triage of the acute things that require the face-to-face stuff. So I agree there's certainly a potential role for it. I just don't think it's going to be a key cornerstone. And I think for practices at the moment who are trying to kind of firefight through a lot of these issues, I think that's where they maybe find the challenge. At a local level at Lockheed, we've done a lot of work and are doing a lot of work around our access, and we've got about 1,500 appointments that we've analysing and are in the process of analysing. A tiny proportion of those did the clinicians feel would a direct near me appointment be a useful thing for. I'm appreciating that from a clinician perspective, not necessarily from a patient one. But there are a lot of other digital things that practices are trying as well. A lot of e-consult is another thing that's some of the practitioners are trying and signing up to. So I think practices are trying to think of things in a digital way in future. But I don't necessarily think near me is going to become a massive part of that in the near future.
Okay, David, thank you very much. Sean, I'll give you the last word in this discussion.
Thanks, Beth. David Wilson has highlighted some of the things. So I want to guess, reassure that as a primary care team, we are looking at how we try to encourage practices to use digital as much as we can for all sorts of reasons. It does improve access. It doesn't necessarily improve capacity, but it can for patients improve access. And also, if we're working in a different way and having less face-to-face, then it changes the type of premises that we potentially need going forward, because you don't need the same type of space for doing a digital consultation as you might do if you were doing a face-to-face consultation. So there's all sorts of reasons. David mentioned e-consult, so we're away to test that with a few practices, so you can put information online, send that, somebody might get back to you just with information, direct you to a website to get stuff, they might be able to just put a footnote back to you, so there's a range of ways that that might support. MedLink is another one that we've not moved forward very well with in Dundee to date, so you could be sent, if you've got asthma, you could be sent a link, you would go online, you would fill in information, the clinician can then review that, and if you need a consultation, they can make a decision as to the best way to do that consultation. And I think that's the type of consultation that David was maybe suggesting could be pre-planned, so your practice nurse who specialises in respiratory disease potentially could do that with you by video, given the information, but they've got more information to make that sort of planned, informed. So we are trying to take forward a number of actions to increase our use of digital as much as we can. The other thing was just about the city centre. So we're working with the vaccination team. We're looking at sort of reprovisioning for vaccinations going forward, and whether there's some utility in terms of trying to provide a little bit more of the frequent care like phlebotomy in a city centre venue, recognising some of the points that Siobhan was bringing up.
Okay, thank you. Right, Ken, definitely, since you opened this discussion, you get the chance to close it. So the definitive last remarks on this, Ken.
Well, that's slightly off topic, actually, but inspired by the discussion about near me, which I found really interesting to hear the different views. Thanks for that. But it's about our own meetings, which are currently near me. I really think we should be moving back to face-to-face meetings with a remote option, because I think everyone's able to use a remote option now if they need to. I know that the City Chambers is now set up for face-to-face and meetings with remote attendees, and I think probably our committee rooms are too. So just to flag that up, that I really think we ought to be moving back in that direction and soon, because there are people on this committee. Well, I've met you, Beth, but it was several years ago. But there's some, like David, who's just joined, who I haven't actually personally met, and I think we lose something from the before and after of meetings, from you're able to maybe extend the discussion or express a particular interest that you can take off table that you can't do online, because as soon as this meeting's over, we all shut down. Sorry, maybe not as brief as I wanted it to be, but yeah, can we please look at going back to face-to-face, the remote option? Thanks.
Okay, we can maybe pick that up at the end under any other business. Just quick, or Arlene, do you want to quickly come back on that, or Dave, Berry is
Roger's on the call. He might want to come in on it.
Roger, would you like to come in on the hybrid potential?
Thanks very much indeed, Beth. I think that's a matter that would be best discussed off table, which I'll be very glad to do with you.
That would be wonderful. Okay, we can look at that, Ken, to arrange something offline. That's great. Thank you very much. Well, thank you. That took a wee bit longer than the actual contents of the paper, but I think it was a worthy debate. Now, we are asked to note the progress made in the premises strategy update and to instruct the Chief Officer to continue to provide progress reports to the IJB on the implementation of the GP premises strategy on an annual basis. So are we happy to do that? Yep. Okay, thank you for that debate then. That was really interesting. Can we move on now to the Dundee IJB Strategic Risk Register Annual Report? And Dave, you're taking this one through, are we? Thank you.
Yes.
Thanks, sorry, Arlene, I never passed it back to you.
That's okay.
Carry on. Carry on to Dave.
Okay, well, thanks for that. So as I kind of mentioned earlier this morning, that the IJB's risk registers considered each meeting of the Performance and Audit Committee, and we bring an annual report back to IJB in terms of the significant issues there and any sort of shifts across our kind of risk register over the year. And just as a reminder for members that the strategic risk register is around any of the risks that may impact on the IJB's ability to deliver on its strategic plan. And more what we're seeing now is some of the operational risks that exist through the Health and Social Care Partnership as they get escalated, kind of coming back to the IJB, because it may impact on our ability to deliver on the plan. So in terms of the report that you have before you, it's a kind of relatively brief kind of overview report, but the details in the appendix. In summary, we have kind of two kind of areas of really kind of significant risk, which are around our staff resource. And again, members will be fully aware of the discussion we've had kind of over a number of months around kind of staffing and some of the challenges that exist around that. For the IJB itself, there is the kind of ongoing debate around the introduction of the National Care Service and what that kind of means for an IJB, although the most kind of recent conversations around that appear to be more or kind of less around the abolition of an IJB as it is, but kind of more a reformed IJB. So that kind of maybe kind of help on our risk levels around that as well. And obviously the financial risks kind of remain, so they have kind of remain at a kind of significantly high level given the kind of funding environment at which we operate in, and we've obviously just gone through a budget process which has required us to make some significant savings, and Christine will obviously come to the financial monitoring position later on in the agenda as well. So that the kind of risk register is there's a live document. It's kind of updated on a regular basis. We do now have a process in place where we have a discussion around clinical care and professional governance risks, which, as I say, need to be escalated up to a strategic level. So we have that kind of regular dialogue around that. And again, some of the issues that we've got on the risk register now are as a result of that, so such as the escalation of some of the property safety issues that have arisen in some of the establishments, that's going to come through, as well as kind of acknowledging some of the implications of new legislation, such as the Safe Staffing Act, which kind of just recently came into place as well. It's not all about risks increasing because of things that we do, activities that we undertake. Some of the risks have gone down, and they're kind of set out in their report as well. I think probably the kind of key one for the IJB to acknowledge is the significant progress that's been made within drug and alcohol recovery service. So that was one that was kind of really kind of high kind of risk on that. But that because of the work that's been done on kind of MAT standards, etc., then that's had a kind of really positive impact on kind of reducing the level of risk around that. So the report is there, and the appendices will hopefully kind of give you all a good overview of what's kind of shifted, what's gone up, what's gone down, and kind of the latest update for each of those. So so kind of happy to take any questions on that.
Okay, thank you very much, Dave. Any questions or any clarity required? Dorothy?
Yes, clarity, please, Dave. 5.5, the two new strategic risks that have been created. Could you point me to them in the risk register, please, or the risk profile? I couldn't find them.
Sorry, Dorothy. So the narrative around that's probably kind of not quite right. These are ones that are being developed. They've been escalated, but they've been developed and not quite reflected in the risk register. So we'll make sure that's in the kind of the next iteration that goes to the Performance and Audit Committee. So the narrative around that's not quite right. So apologies for that.
Okay, thanks, Dave.
Thank you, Dorothy. Any other questions or points of clarity for Dave? Okay, the recommendations are that we note the progress made in the Dundee Health and Social Care Strategic Risk Management, including new clinical care and professional governance meetings focused on considering operational risks against strategic risks. Are we happy to note that? Note changes in the specific risks in the strategic risk register, including changes in scoring of existing risks, recording of new risks and archived risks. Okay. And to note the future work plan to further embed strategic risk management in the IJB. Okay, so thank you for that. I'll hand back to Arlene.
Thank you. That takes us on to item 9, Audit Scotland Annual Audit Plan 2023-24, and you're asked to agree the recommendations.
Okay, thank you for that, Arlene. For this, I've got Christine Jones, and you're joined by colleagues from Audit, I gather.
Yes, thank you. Yeah, I'll just quickly introduce the paper and then I'll pass on to our colleagues from Audit Scotland. So yes, this is our the annual audit plan for our external audit for our annual accounts. It's obviously a report that we bring each year to yourselves with the audit plan. We are currently with our second year with the current Audit Scotland team. And just in a second, I'll pass on to Rachel Brown and Mary O'Connor to take us through the paper and the plan, which is obviously attached in Appendix 1 for everyone to see. And just another thing, just for noting in terms of timescales for presenting papers and reports back to the IJB, we do plan to bring the unaudited accounts to the IJB meeting in June for 23-24 for signing off, and then we'll be passing that on to Audit Scotland to work through the audit process, and then the audited accounts will be presented to them in November, so to the PAC in November. So just to highlight that timescales in terms of the board's involvement in the process. But I'll pass on to Rachel just now, and then I think possibly on to Mary afterwards.
Thanks very much. I'd just like to introduce myself to the IJB. Just to say I'm your new appointed auditor following Brian Howarth's retirement last month. So this will be my first year as your appointed auditor. To say I'm an audit director in Audit Scotland's Audit Services Group, and I have around 25 years of public sector audit experience, which covers local government, NHS and central government, and that includes IJB audits. Also the appointed auditor for Perth and Kinross IJB and Perth and Kinross Council and Dundee City Council and NHS Tayside. They form part of my audit portfolio. So I have involvement in various aspects of health and social care audits in this area. Just to say, I'll let Mary run through key points of the plan shortly. I'll just draw a couple of points to your attention, just to point out that the timing of the audit, as you will see, is not in accordance with the target timescales. We are still catching up essentially post-COVID, and we have some significant staffing challenges or national challenges around recruitment to finance posts and audit and accountancy posts, and we are experiencing that. So part of our plans to recover audit delivery timescales are around recruitment. So we are recruiting professional trainees. It's very difficult to hire people who have audit experience. So we bring in people at a trainee stage and then train them. So that means it takes a bit of time for them to learn how to audit, to give us more capacity to bring forward audit timescales. But we are investing in that process just now. And also to say that we are prioritising certain audits. We are prioritising the councils and the health board audits. So they will be done before the IJB audit this year. But then that in some regards helps us because we take audit assurance from the NHS Tayside audit and the Dundee City Council audits to get our audit assurance to sign off your accounts. So while it's unfortunate that we will be reporting in November, actions are in train to bring that forward incrementally in future years, although I expect it may take the rest of the 5-year audit appointment to recover those timescales fully. So just to give you that background information. And also to assure you that while I know that an increase in an audit fee year on year is not welcome, we are also required to make efficiency savings as an organisation, as a central government body. So we are very focused on the efficiency of the audit approach and restricting any fee increases as much as possible. So I I can't bring the fee below the expected level, so we have set it at that baseline expected fee level on the understanding that there will be appropriate internal controls in place. So you're paying the lowest fee that I am able to set for this year to just give you that assurance, and more information, should you want it, on efficiency savings to be made by Audit Scotland are in our budget proposal to the SCPA, which is available on the Parliament's website. So I was going to hand over to Mary to run through a few key points. So if you could bear with us, under auditing standards, there's certain things we have to draw to your attention as those charged with governance. So Mary will do that in a minute. And I'll just draw your attention to paragraph 8 in the plan, where we are asking you as members of the IJB to bring to my attention any matters concerning actual or suspected fraud, or any concerns around fraud risk in the IJB that you may have. We've had planning discussions with management and with internal audit, and from our perspective, there is not a significant fraud risk. You'll see set out in the plan that we've rebutted certain presumed risks, but we are required to hear from those charged with governance if you have any concerns in that regard. So I'll pause there and let Mary run through the plan, and then we'll both be happy to take any questions at that point. Thank you.
Thank you, Rachel, for your introduction. Welcome. Mary, do you want to take over?
Yeah, thank you, Chair. So our 23-24 annual audit plan is included in pages 43 to 58 of your papers today, and this gives an overview of the external audit work planned for the 23-24 financial year. Hopefully the document should be fairly self-explanatory, so I'm not going to go through it in a lot of detail, but as Rachel says, there are a few areas that I need to highlight for members' attention, and then we'll be happy to answer any questions that you may have on our planned audit approach. The first section of our plan covers our approach for the financial statements audit and the work that we require to undertake to support our opinions for the 23-24 annual accounts. Within this, Exhibit 1 sets out the materiality levels that we have set for the 23-24 audit and explains the basis for these figures. When we talk about materiality levels, these are the figures that we may assess any errors identified during the audit against, to determine whether the value of the errors indicate that the financial statements may not provide a true and fair view of the body's financial affairs. So effectively, these are our levels of tolerance for misstatements in the annual accounts, and these also inform our approach to the audit. Exhibit 2 then details any significant risks of material misstatement that we have identified for a 23-24 audit. These are the areas where there is an increased likelihood or opportunity for the financial statements to be materially misstated. You'll see that we've only identified one such risk for the 23-24 audit of the IJB, and that relates to the opportunity for management to override existing controls to manipulate the financial position reported in the accounts. I should highlight that this is a standard risk that is required for all audits and is therefore not in any way a comment on the management of Dundee City IJB. However, ISA 240 requires us to design audit procedures to address this risk as part of our annual audit, and our planned audit procedures are shown in the final column in Exhibit 2. Moving on to Section 2 of the plan, this covers our additional responsibilities as public sector auditors under the Code of Audit Practice. We've not identified any specific areas of risk within the wider scope audit. We will follow up on all recommendations made within the 22-23 annual audit report with management as part of the audit process. The next section sets out our reporting arrangements and the proposed timetable for the 23-24 audit. So Exhibit 3 details our planned audit outputs for the year and the committee meeting that each of these will be presented to. And then Exhibit 4 sets out the proposed timetable for the final audit accounts that will enable us to certify the 23-24 audited annual accounts. The final paragraphs in this section detail the fee for the 23-24 audit and the factors we've considered in reaching that fee. The final section of our plan explains the approach to working with internal audit to maximise the effective use of audit resources, the arrangements we have in place to ensure our independence and objectivity to conduct the audit, and also our internal quality control arrangements. So, in conclusion, They are the main areas of the plan that I wanted to highlight. So I'll just hand back to you, Chair, and see if any of the members have any questions for us on the planned approach for the 23-24 audit. Thank you.
Thank you, Mary, and thank you, Rachel. Any questions for either Mary or Rachel, or even Christine that you want to come in? Dorothy, could you like to come in, please?
I think this is was addressed already, but 4.5 in the report, it's about the timetabling to approve the audit accounts, and we're not going to meet that published timetable. It says signed accounts must be published no later than 31st of October, but I believe it's going to be into November. Is there any penalty for that? I mean, is that, you know, will that be okay? We won't get into trouble from anybody for not having the signed accounts done on time? Or are there local authorities and IJBs in the same position?
So, Chair, can I come in on that?
Yes, Rachel, please.
To answer, no, you won't get into trouble on that basis. The Accounts Commission are aware of the difficulties across both Audit Scotland and the private firms that deliver public audit in Scotland around the pressure. So they are aware of the prioritisation approach that we are taking, and they are aware of the planned sign-off deadlines. So there shouldn't be any comeback. There is a requirement to publish a notice on the website to give the estimated publication date where you're not meeting it, but there's not going to be any penalty to the IJB. It's more about audit capacity being built up and keeping the Accounts Commission assured that that's happening, and ensuring transparency for anyone who might wish to read your audited accounts and annual audit report, so that they're aware on the website of when that will be available.
Okay, thank you.
Thank you, Rachel. Any other questions, Dave?
Thanks, Beth. So not a question. I'm probably just going to draw to the attention of the IJB kind of members around the areas of significant risk. So in terms of well, it's down in Exhibit 2, there's only one kind of area of risk that's been kind of flagged up, and in previous years we've probably had quite a kind of few risks identified through either the financial kind of risk or indeed the wider dimension risks, and I think that's probably kind of testament, and the fact we're down to one now is kind of testament to the good kind of joint working we've had between ourselves and external audit and internal audit in terms of identifying the risks, identifying actions to kind of to mitigate against those risks, and then kind of reporting them back to the IJB. Now that's not to say there aren't risks out there, and as the audit progresses, there will be potentially some areas that our kind of audit colleagues, both internal and external audit, will want to kind of comment on over both the kind of the course of the audit itself, but also as a reflection of our overall sort of governance environment. So I think just kind of want to put that back to the IJB members, that this is a much kind of reduced risk kind of level of reporting or action plan that we've kind of seen in the past on that.
Okay, thank you, Dave, for that. Anything else? Nope. Well, it's recommended that we note the contents of the report. We approve the proposed audit plan for 23-24 as submitted by Audit Scotland, and explicitly note the requirements under paragraph 8 of the audit plan 23-24 as detailed in 4.3, requesting that any instance of actual, suspected or alleged fraud should be brought to the attention of Audit Scotland for consideration. So are we happy to approve this? Okay, thank you very much. Thank you for coming along, Mary and Rachel. Okay, Arlene, we'll hand back to you.
Thank you. That takes us on to item 10, financial monitoring position as at February 2024, and this is for noting.
Okay, Christine, it's
Thank
your
you.
bag again. Take it away.
To just about close out the meeting. Yeah, thank you. So this is again our regular monitoring report that we bring to yourselves. This is our position as at the end of February, so 11 months of actual plus our final month or so of to take us to the end of the financial year. The position at the end of February, or the projected position based on the February numbers, is showing a net operational overspend of about £3.5 million projected for this financial year. That is an improvement on our previously projected position, where we were at the end of December, we were projecting a position of £4.8 million overspend. So obviously that's an improvement and better news for us in terms of looking for this it just ended financial year, and also then has a better position in terms of reliance on reserves, as this is now within our earmarked reserves that we've set aside to cover the anticipated overspend for 23-24. As always, the details of some of the variances and movements and underlying reasons are noted through the report, and the figures noted in the appendices. Key point to note, or a couple of key points just to note and to bring your attention to, we have seen quite a significant improvement through prescribing during the financial year for Dundee GP prescribing position. You may recall when we set the 23-24 budget, we were anticipating a cost pressure of around about £1.5 million in our GP prescribing due to quite significant volume growth and demand and pricing growth. Well, we have seen a level of growth that's come through this year and a level of increased spend. It's not materialised at quite the kind of planned assumptions that we'd actually built in. So we've seen a better position than anticipated. I have to say that I would love to know some of the real nitty-gritty reasons why, because this position within Dundee isn't really replicated elsewhere. Elsewhere across the country, there is increased spend and increased deterioration in their prescribing. So there's obviously positive steps in terms of the ongoing trend that we have seen over a number of years through our GP prescribing. So that's obviously a good position to be in. Just on a side note, from an end of year financial position, we have seen a slight deterioration with that. So it's by the time we get to the end of the financial year, the provisional figures for that does show a bit of a jump towards the end of the year, but certainly not to the kind of anticipated levels that we were anticipating for the 23-24 overall financial position. As it's been highlighted already through the risk register and the other conversations, we continue to see significant staffing vacancies and staffing challenges and recruitment challenges across the whole of the Health and Social Care Partnership. Again, this is not a unique position to Dundee or even to Tayside or to particular job families. It is quite widespread across and obviously even replicated with our colleagues in Audit Scotland and elsewhere across the public sector. So it's that ongoing underspend and challenges due to staffing vacancies there. But the flip side of that is there are obviously areas that we need to manage and risk and skill mix and safe staffing levels. So there is a reliance on supplementary staffing and agency and staffing and bank nursing, etc. in certain areas. So that premium cost of that does obviously impact in terms of some of the cost pressures that we see in certain pockets of areas where we absolutely have to maintain safe staffing levels and bring in additional staffing in certain areas. And we're obviously continuing to see demand for care at home packages, which again is obviously causing an ongoing cost pressure that we've previously reported and previously discussed, and obviously recognise that cost pressure on a recurring basis as part of our 24-25 budget setting proposals as well. So that's that situation hasn't necessarily changed. And a couple of other points in terms of the wider position within. You'll notice perhaps the Appendix 3, I think it is, for lead partner, or what was previously known as hosted services, the Tayside GP out of hours service via Angus IJB continues to present quite a significant Tayside-wide overspend position due to changes in demand during and post-COVID, resulting in consultation times being longer due to more complex case mixes. A recovery plan was requested via Angus Health and Social Care Partnership's executive management team. That has recently been presented, and I think there has been some savings that are gradually being implemented, but we're waiting to hear further conversations and discussion about that position and how the impact of that will be going into the new financial year from that position. Table 2 under 4.6 indicates our indicative closing reserves based on the information in this report. Again, that will be finalised as we go through the year end, but that gives a bit of an indication as to where our reserves are, and likelihood is once we do get our closing year end position, we will bring to something to perhaps to the June IJB in terms of reprofiling and reviewing the reserves position that we have, and perhaps looking at increasing sort of transformation funding to continue to support the transformation planning and continue to sort of pump prime that. So that type of thing may be brought through in terms of our proposals once we get our full year end of year numbers for the reserves. But that just gives an indication as to where our reserves position is anticipated to be. Given that we are and we're looking at an overspend, quite a significant overspend, we were tasked with detailing a financial recovery plan, given that we're relying on reserves. The plan is, or the summary of the actions taken during the years noted in 4.7, just for assurance and completeness purposes, but we are, as these figures are stating, we are no longer reliant on additional general reserves to cover our overspend position. We are able to utilise the ring fence reserves for that we earmarked for this purpose. And just a final note, just for which obviously ties into our previous item, within the June meeting, we will bring a comparable report alongside the statutory annual accounts to yourselves to close out the financial year for 23-24. The statutory accounting treatment of a number of items will present the numbers in a way that may look very different and may look unfamiliar to yourselves. So just to aid your understanding of where the numbers have actually come through at the end of the financial year, we will bring a report in this format to the IJB in June, and be able to make this a comparison to the June to the annual accounts that we will be presenting and handing over to the Audit Scotland. So just for awareness that the annual accounts, the unaudited annual accounts, will likely look very different in terms of sort of bottom line numbers. And I know in the past it's raised questions about exactly what it means. So we bring this format to you as well in June. Is there any comments, questions, feedback?
I'll throw it open then. Has anybody got anything they want to ask? Dorothy?
Yes, thanks, Christine. Quite a comprehensive report. 4.4.2 talks about recruitment and retention challenges producing an underspend. And at the same time, 4.3.4 speaks about reliance on bank, agency and locum staff with premium costs. So I'm just wondering about the balance there. You know, we've got an underspend and an overspend. Do we still have is it still an issue, the premium costs for agency, bank and locum staff?
Yes. Yeah, so I mean, obviously we will have underspends in some areas, and those vacancies may not be essential that we absolutely have to fill for safe staffing levels, etc. Decisions will obviously be made in terms of how we deal with some of these vacancies. Some of them will just continue to be held. It will impact on sort of capacity, but it's perhaps not an essential role in terms of patient-facing, service user-facing types of roles. So some vacancies will continue to be held while managers continue to look at recruitment opportunities, maybe changes in skill mix or different job families to backfill vacancies that we have. where so that may be the things that are driving some of the reportable underspends that we've got in certain lines. But the flip side is there are teams that we absolutely have to bring in additional staffing because of safe staffing levels in wards, or we've got care at home packages, community nursing appointments, whatever it might be, where we've got a patient facing or service user facing, and we absolutely have to bring in additional staffing to maintain these services and maintain these appointments. And so where that situation arises, then yes, there is a premium cost for bringing in, whether it be overtime, bank, sessional, or agency staffing. Obviously, decisions will be made to minimise the agency staffing because that's obviously the most expensive. But yeah, so there is both situations occurring. And again, we've got sickness absence levels and things like that as well, that we and through wellbeing efforts in both organisations, trying to support staff back to work as well to help ease the issues.
So, and I imagine another thing to put in the mix are the new regulations around the implementation of safe staffing. That just to complicate things further. Okay, thanks, Christine.
Dave, do you want to come in?
Yeah, just an additional comment there and around the use of agency side of things, which is something we obviously was kind of a bit of a last resort in terms of kind of making sure we have kind of staff cover. But just to kind of advise the board that there's been work done kind of nationally, because obviously it's a national issue around the kind of the increased what are called supplementary spend, particularly around agency. And also kind of more locally across NHS Tayside around the kind of use of agency. And over the course of this current financial year, we should start to see a kind of significant reduction in the use of agency across all our primarily our NHS kind of staff to be in terms of the work that's been done nationally, but it is an area that we kind of look to we continue to look to minimise, but we'll follow what's happening across Tayside on that.
Okay, thank you. Jim, do you want to come in?
Yeah, thanks, and thanks for the paper. First of all, we want to kind of say that it's good to see it acknowledged in the paper that the kind of increased spending in care at home has a knock-on effect about saving elsewhere, about delayed discharge and stuff like that. Something that we've kind of all acknowledged for a number of years, that the whole strategy around people wanting to live in their own home or their own community longer, and that needs investment and stuff like that. So that is welcome. The other stuff around obviously the spending on agency across both things. Welcome Dave's comments on stuff like that, but I do think it's a whole issue, isn't it, around kind of planning the future workforce to meet the kind of demand that we expect for those type of services, and anything that kind of can reduce that, I think, is really important, including investment in the workforces of both the NHS and the local authority and other care providers, because there are some, we have to acknowledge, look, there are some of these agencies and some of these companies making a hell of a lot of money out of public services, and I understand why they need to do that at short notice at sometimes. But we need to really do everything we can to kind of reduce that, because that money should be, spent kind of in our communities. It's not even as if a lot of that workforce makes that money. It's the agencies that make most of the money out of profit. So I think it is important that we continue to look at that, about kind of developing that strategy about investing in our own existing workforces and stuff like that, and reducing anything that goes out with.
Okay, thank you. Susanna, do you want to come in?
Yes, thank you, Chair. I guess just to add on the back of Dave's conversation there around reduction in the amount of supplementary spend and agency, and Jim, your comment about investing in the workforce, just to bring it to the forefront around some of the work that we're doing around newly graduated practitioners as well, and looking towards what looks like at times we will be over recruiting, but recognising that actually we only have one outtake per year from the universities. So there's been a big piece of work across Tayside as well to look at attrition rates across the patches, what's our supplementary spend like, and how can we ensure that we're supporting the workforce of the future by bringing the NGPs forward. So there's been a really great piece of work there, and we're sitting at probably near enough 70% of the newly graduated practitioners all being placed within, certainly from a health perspective. So it was just to bring that into the conversation as well.
Okay, thank you, Susanna. Any other points? Nope. Well, thank you, Christine, for that. We've been asked to note the contents of this report, including the overall projected financial position for delegated services for 23-24 financial year end, as at 29th February 24 as outlined in the appendices, and to note the steps that continue to be taken by officers to consider options and opportunities to improve the financial position during the remainder of 23-24 as part of the financial recovery plan process as outlined in section 4.7 of this report. So I'm happy to say we've noted it. Okay, thank you. And back to Arlene.
Thank you. That takes us on to item 11, which is the attendance return, which is submitted for information.
Okay, thank you. So if you have a look at that, and if there's any points that you are not happy with or you think is slightly wrong, if you contact Arlene, that would be good. Can I just say at this point that this will be my last meeting as chair. So I want to thank you all for your support and your courtesy and putting up with my chairing and my little idiosyncrasies. But it's been very good working with you, and I shall still be here as a member of the Dundee IJB, and Bob will be taking over from the beginning of May. And I look forward to supporting him in his transition into the chair's post. So the only thing left for me to do is go back to Arlene for the date of the next meeting.
Yep, which is Wednesday, the 19th of June at 10 o'clock.
Okay, and we'll be updated if there's any changes to the online position after offline discussions with council. Okay, so thank you very much, folks. It's been a good meeting, I think. We've gone right, just coming up for lunch, 12:57. So I hope you have a nice lunch and yeah, enjoy the rest of your day, and we'll speak soon. Take care. Bye.
Thanks all.